Today we're gonna be playing full code. Oh, this is gonna be fun.
Rock was harmful. No, this is not what I need for a patient.
Full Code is a medical simulation game, and since I now am an ED tech who works in the emergency department, I need to brush up on my skills and treat patients. This game comes with free cases that I get to test where people are experiencing certain conditions. So let's begin. Pressing on all cases right now. I have gone through 3 already, which is why you see the percentages here. In pre-med club, where I was introduced to the game, you can see the first one was 20%. Not sure if there's a passing score, but if the patient dies, I think that's a fail. So we are going to try to beat my score of 64% for case 78, where I found someone lethargic by a roommate. And you know what? I think we're gonna go with this one right here, number 15, pale and weak with a fast heart rate. I like cardiovascular problems, if you can see behind me. This should be a good one. Here we go. Case introduction. EMS report. A 40-year-old male was found at work pale and lightheaded with complaint of acute onset palpitations. Heart rate is 180 in the field, blood pressure is 95/66, and there are no known past medical history. Now BP under 90 systolic would start alerting me to shock. That's what I look for. And 40-year-old male, okay, found at work pale, lightheaded, probably poor perfusion. Could be beyond the cardiac system, cardiovascular, lungs. Once I press begin, time starts. So I don't want to press begin until I kind of have a general idea. So yeah, triage nurse. So heart palpitations, of course, that's our direct contact with what we're looking at. Heart rate 180, looks ashen, so definitely that pale looking skin, signs of poor perfusion in the blood. No known cardiac history though. So 40 years old, could be experiencing minor heart angina. The palpitations is what I'm not quite as familiar with. Direct to resuscitation bay. Well, I am just someone working here. I have a nurse and attending physician I can contact with, and I guess I'll just start taking tests. Let's first here see the attending physician. Can the attending physician help me with this diagnosis? Well, that's helpful. It's up to you to figure out the final diagnosis, but I filled in the differential. Let's review that. Okay, so cardiovascular, he has, an acute mitral valve rupture. So a mitral valve is on your left side of the heart. It's also called the bicuspid valve. So we see that that has rupture. And then acute pulmonary edema. I'm not sure if these are saying he has these or if these are things to look for. That could be a question, but the patient is injured here, so let's continue. So let's see the differential with that. Okay. I should probably have looked over how to play this game. All I know is I need to take tests and stabilize. So let's insert an IV. That's actually one of my jobs at the hospital. Get that in case they need to administer drugs or take blood samples. Definitely attach the monitor. Chest compression's not needed, the patient's conscious. Fluid level, oxygen. Let's see, oxygen sat's 98%. Looks good. Let's see, fluids. Let's investigate. Let's begin lab work. Let's do blood gas. Check to see what his blood results are like. Okay, so his blood. So pH is 7.42. Physiologic pH is about 7.2. Perfusion of carbon dioxide, 37 millimeters of mercury. O2 is 93, that's good. It would be good to test, let's see, creatine kinase levels, cell count, glucose. When the heart is injured, it starts, I don't see albumin levels, so I don't know what other lab work to do here. Calcium levels would be good to see, so we'll do some calcium levels. Calcium levels, 9.6 milliliters, okay. Slightly elevated, nope, in the normal range, okay. Let's see, heart rate is elevating, so we want to stabilize with some fluids. Might as well give some saline. Respirations are slightly elevated, pretty normal, but his blood pressure is dropping. So to add some more volume to the blood, the saline can hopefully help. Let's perform a circulation exam in progress. So 1 peripheral pulse, that's good, delayed capillary refill. So yeah, poor perfusion. Let's make sure nothing's going on with his lungs. Clear auscultation bilaterally, no retraction, so his lungs look good. Cardiovascular exam, time to just start running through exams. Okay, tachycardic, we know that his heart rate's up at 180, regular rhythm. Okay, so palpitations, I'm trying to think what that might be. Let's see, if I consult cardiology, let's see what he thinks. So this patient has a narrow complex tachycardia, which could be sinus tach. So the SVT interval on the EKG, or regularized atrial fibrillation, rapid ventricular response. See if you can slow them down or chemically cardiovert them. So in the hospital, I have not had to slow down someone's cardiac problems or try to raise blood pressure. So let's try to see meds. Don't want resuscitation meds. I want something cardiac. Adenosine bolus might be good. Okay, let's see. Don't want nitro. His blood pressure's already pretty low. Propranolol, no. Let's see. Some baby aspirin for cardiac things. That's the first thing we learn as EMTs. So I'll give him some aspirin, see what that does. I don't see any contraindications for that. Let's see. Yes, that is the one thing I wish I was better at. I still don't know a lot of medications to give. That's kind of the nurse's job at the hospital. So let's continue to see this. His heart rate is not really changing after the aspirin. Blood pressure is the same. So this is concerning, to say the least. But I don't want to lose him. So let us see here. I don't need to intubate. He's breathing fine. Pacer. Okay. Not sure what synchronized cardioversion is. Should I try it? Let's see what that does. Okay, don't need that. Normal saline, okay. Saline rings. Let's communicate. Let's consult cardiology again, see what's going on. Okay, this patient has a narrow complex tachycardia, yes. Okay, I've tried slowing it down. Nothing's happening. Let's see. Okay, no more exams needed. Intervene. Let's do some meds. Adenosine bolus, so it did not convert him. That's unfortunate. Let's see, the attending physician, I need some help with some key actions. Look for the check symbol, okay. So cardiac, he has some atypical chest pain, fitra. He hasn't had syncope, don't know about the rupture. Can't tell. Cardiac tamponade is kind of where the pericardium sac fills with fluid. Myocardial infarction, doesn't look like it. But his heart rate is increasing. Okay, patient. Okay, so 40 years, full code. Ooh, I have a conversation, but right now that's okay. Okay, he's taking omega-3 supplements, known allergies, social, ETOH, no illicits, no tobacco. Okay, ask about cardiovascular. Okay, palpitations and mild shortness of breath. So mild shortness of breath, no chest pain. No chest pain is a good sign. And then no, recent exercise intolerance or syncope, so there's been no passing out, except he's clutching at his chest now. Let's see, fluids. Let's increase that saline to 1 liter. Here's some more drug choices. So propofol, I have actually had administered to some people, hip fractures, some other cardiac episodes, possibly. I've seen some succinylcholine and some ketamine in the hospital. So those are the ones I'm familiar with. That is helping his heart rate slightly, still elevated, and his blood pressure is now in the shock stage. So definitely the fluids, I want to keep him warm. What else can I do? Let's see, midazolam. Okay, I don't know. Oh, meds for intubation. Okay. Phenylephrine,
will increase his heart. We don't want that. We want something to slow it down. You know what? Ketamine. We'll see if that... Oh, great. The patient is now no longer conscious, or at least unresponsive. Sedation. Ibuprofen. Something for the pain. Well, this is not going as well as I'd hoped. I don't know what else to administer when his blood pressure continues to deteriorate. So blood pressure is deteriorating, worry about shock. Fluids should help. Something about his tidal volume could be decreasing in the heart. His heart rate's going back up. Let's do another circulation, so still delayed. I'm not sure about the other infusions. Okay, intubation is not needed still. Good. I have no idea. Let's see. The contraindications. You know what? When in doubt, contact cardiology again. Okay. This patient has a narrow complex tachycardia, which could be okay. Same things. Consider electrical cardioversion. Not sure what a synchronized cardioversion is. Should I try it? Let's see what that does. Okay. So if I try to... No, don't do chest compressions. No. Stop. I don't. Stop chest compressions. Okay. I do know. He has a pulse. I should not be doing chest compressions. That was an accidental click. Let's stop. Can't stop it. Okay. Well, this case is not going as well as I thought. Yeah. Vascular access. Second IV. Second IV could be helpful. You know, getting a little more saline or administer some meds there. I'm curious, electrical cardioversion, how can I do that? Let's see, lab work. Let's see about his, troponin levels. That is very important for the heart. Troponin levels are within normal range, so nothing looks crazy there. Let's see, urine analysis, which is another job as an ED tech to get. See about that. Glucose is negative, ketones none, nitrates. So yeah, overall, normal looking results. So something about the heart palpitations. There's could be a blockage in his heart. Cardiac. Let's see about some statins. So statins is a name I've heard of. I'm not exactly sure its mechanism of action. See if that helps stabilize. Heparin is blood thinner, which if there's a blockage, might be good. You know, never know. So might as well give it. Again, don't want to give nitro because his blood pressure is already so low. That's at least one I know as an EMT. Heart rate still 170, blood pressure 79. I cannot stabilize his blood pressure. If I contact... Let's see if I consult pulmonology. The pulmonology is not sure why you called. Yeah, chest x-ray if I suspect some sort of chest trauma, so pulmonology is probably not helpful, that's true. Let's see the physician. Look for signs of shock. Yes. As noted, blood pressure, shock. So usually we say keep warm, lay supine, so he's supine. Check about that. Okay, how can I stabilize? Patient's unstable. Yes. Thank you, I know. I can look on the patient. Okay. Well, that is interesting. Okay. Oh, look at this. The heparin was harmful. I have this list of things to do and not do. Okay. Recommended. Assess for pulmonary edema. That would be good to see here. Perform Breathing exam. Bilateral, perform airway exam. Yep, we'll do that. Let's just go through the exams. Perform neck exam. I'm out of options here. Clutching for straws, you know? No masses. Trachea's midline. Supple, okay? Okay. Yes, the chest compressions were harmful, and now the heparin was harmful, which, okay. I've been working for 13 minutes. Let's see what else I can do. Okay, intervene. Some meds for cardiac. Okay, sedation. Okay, the fentanyl bolus. Fentanyl relieves pain, doesn't really help with the heart. Morphine. Yeah. Okay, the meds. Something about these meds have the check mark. Phenylephrine. Rocuronium. Okay, rock is a go. Okay, I must pre-oxygenate for intubation. Well, you know what? Might as well make sure his airway stays patent. So let us do that. Let's position for intubation and pre-oxygenate for intubation. Because why? I don't know. And let us give some rock. I really hope that's not like the heparin and it's harmful. Oh my. Okay. Blood pressure. Yep, not changing. Well, let's see what I did. Rock was harmful! No! This is not what I need for a patient. Okay. I've gone through rock. Succinylcholine, choline, probably not helpful either. What else can I do? Okay, got fentanyl bolus. That's just pain relief. Lorazepam. Okay. I have him sedated, so that's not important. Okay, cardiac. I've done the atorvastatin, metoprolol. You know what? It's up high, so let's do the amiodarone, or however that's pronounced, infusion. Was that? That was also harmful. What am I missing? I need something else. Recommended. Perform calcium level. Yes. Okay, recommended, critical, neutral. Nothing else has been helpful. Okay, what about the nurse? Check with the, okay. The nurse is very helpful. Check with the attending for advice. Okay, advice on investigation. A few things that need ruled out. Okay, false positives, yes. Advice on interventions. If the patient's blood pressure is low, you should address it. I don't know what else I've been doing for the past 10 minutes. Okay, yes. Do I need handoff to ICU? I can't see him stabilize. Okay, final diagnosis. Supraventricular tachycardia. That seems to be a definitely likely thing. So supraventricular, it's above the ventricle, left or right, and he's tachycardic. He has a heart rate of 170 that hasn't reduced. So myocarditis, probably not. The palpitations don't seem to be linked to that. Pulmonary embolism, we've ruled that out. Atrial fibrillation, his heart rate seems typical, not indicative of fibrillation need with the defibrillator, and atypical chest pain. I'm gonna say supraventricular tachycardia. Myocarditis is the second choice, followed by atypical chest pain, but I would probably admit to ICU. And I definitely missed some things that I need to do, but I am at a loss. So let us see if I did that correctly. So admit to ICU with a diagnosis of supraventricular tachycardia. Am I sure? No. Should I hand off? Or should I continue probably administering harmful drugs that could worsen this condition? Nothing I've done so far has helped. So, wait, hang on, finish. I don't know. Okay, I'm hanging on. Just maybe, what else can I do? So I've performed abdominal exams And let's also do a skin exam. It'll probably be cool, pale. Yes, he is in shock. Stabilize. How else can I stabilize? So I've intubated him. Okay, perform the ET tube so we keep his airway patent. Yes. Okay, drug choices. I've given him nothing that has actually been helpful, except the ketamine and propofol, I guess. For his heart, clopidogrel, whatever that is that helpful? Oh, it was unnecessary. It wasn't harmful. That's a step in the right direction. Okay. T and K. What is this? T and K bolus? Was that helpful? Okay, it's harmful. I don't know what else I can do. Lab work. Bedside test. Oh. I can't believe I missed that. That is something that I do often, the EKG or ECG as it has here. I don't interpret the results, but I take them. You end up putting 10 stickers all over the patient's heart region, and then it takes 12 images of the heart. So it says tachycardic and irregular rhythm. Because of that, with the leads here, you can see I'm definitely going to say that he has supraventricular tachycardia. I am missing some other things, but I better get him to the ICU. My final diagnosis is a supraventricular tachycardia, and with that, I shall hand off. That hurts. 35%. Ow. My diagnosis was correct, but not much else. I think it's safe to say that my position as an ED tech and not a nurse is, so far, for the patient's best interest, and I need to review more things on how to increase blood pressure properly and how to manage shock more than just the pre-hospital setting like I've learned as an EMT. Well, that has been part 1 of Full Code. If you guys liked this, then I'll make another one. If you found it helpful or just interesting to learn a little more about the ED setting from an ED tech, then that's what I'm here for. This is Learning with Landen and Ad Meliora, toward better things.